Uh, good day. My name is Chris Copeland. I work for CCSI as a consultant, and welcome to Module 11 of the Beyond the Tip of the Iceberg data series. Today, Emily Kingman from ICL is going to be talking about using data to improve health outcomes. She's one of our outcomes champions. So I just want to orient you to the matrix. Today, Emily's going to be talking about the use of data to change health outcomes of a demographic group of people who receive services at ICL, and working from the overall large group to using data that is program specific and very specifically to data that is client specific and able to change individual health outcomes. So I'd like to hand it over to Emily now, and thank you for your presentation. We're looking forward to it.
Thank you for having me. So ICL provides a wide range of behavioral health, housing, shelter, care coordination, and outreach services throughout New York City. And at ICL, whole health is a strategic priority. By expanding our scope, which historically has been mental health, housing, and addressing other social determinants of health, to include physical health, we're better able to prevent avoidable hospitalizations and support people to live longer, healthier lives. So to make an impact on health outcomes, we need data. And in deciding on what to measure, what data to collect, we really focused on aligning ourselves with managed care, HEDIS, QAR, and other national measures. Capturing health data also provides us with an increased opportunity to obtain funding and for advocacy to support our work. Central to our efforts has been leadership's investment and commitment to integrated health and the allocation of resources to support our work. So we have outcome evaluation staff who are dedicated to data collection and analysis. We have developed written materials which are focused on health education and activation. And it's also been critical that we've been able to obtain some funding to supplement existing resources and really help to drive the work forward. Collecting health data holds all staff accountable to ICL strategic priorities. So what is it that we're collecting? In 2017, we started collecting blood pressure and BMI every 6 months, and also connection to a primary care provider. And we've since added some additional measures, including A1C, cholesterol, flu vaccination, and tobacco use. Taken together, these are key markers of cardiovascular disease, diabetes, and cardiometabolic syndrome. And they're really important measures to monitor for preventive care and chronic disease management. So when we first began collecting this data, we were asking each program to track it on Excel spreadsheets that they were then submitting to the outcome evaluation team for analysis. A recent important gain that we've had has been to build a health measures form directly into our electronic health record. So this allows for easier analysis of data, and it's really important that the data has now become a part of the record itself and not existing outside of it. So this really provides an opportunity for, at the individual level, to use the data for clinical decision-making in real time. We have established a feedback loop to share data findings with program and division leadership. So the outcome evaluation team shares user-friendly reports with aggregated data where, as you can see from this excerpt of a report here on the screen, they highlight areas for impact. These reports are done for each program and program type, but then also at the agency level, it's a way for us to use data to determine which quality improvement initiatives to focus on. So I wanted to share a couple examples of the ways that we're putting this data to use. and to improve quality and impact health outcomes. So the first example is that we identified individuals with elevated blood pressures in our supportive housing programs and implemented a simple intervention. We asked the housing case managers to take blood pressures using portable wrist monitors. We made nursing support available to the case managers to talk through and address elevated blood pressure readings. Case managers encouraged individuals with at-risk blood pressure to see their primary care provider, or they made linkages to primary care as needed. The case managers also had use of the ICL's Healthy Living Workbooks, which are a great health education resource that can help to develop person-centered action plans. The workbooks use motivational techniques to increase activation, and they're really a great tool to help promote chronic disease self-management. So as you can see from this graph, prior to our intervention, at-risk blood pressures were actually increasing in our housing programs. And then with the intervention, which was just simply providing health education and encouraging people to connect with primary care, we saw a decrease in blood pressure and at-risk blood pressure. Only 57% of those with an at-risk blood pressure still had an at-risk blood pressure a year later. So as you can see in our treatment apartment programs, 52% no longer had at-risk blood pressure. In supported housing, it was 37% were no longer at risk. In congregate residences, 43% no longer had at-risk blood pressures. This represents a really significant reduction and is an important preventive measure to reduce health risk. The second example I wanted to share is a grant-funded project to improve health outcomes in our ACT population through integrating primary care into the assertive community treatment ACT model. At our East New York Health Hub, where 4 of our ACT teams are located, we have a co-located federally qualified health center, which is operated by Community Healthcare Network. And through our grant, we've been able to bring on a CHN provider as a PCP consultant 1 day a week. We hold bi-weekly meetings with the primary care provider and the ACT team nurse and prescriber to review each team's health data registry. And we use it as a tool to develop action plans to both mitigate risk for people with elevated values or who have other medical risk issues, but also as a way to ensure that all participants are receiving preventive care. So what you see on the screen here is a sample of the data registry that we use on this project. So you can see that elevated values are highlighted in pink to help draw attention to where action is needed. What you can't see here is the last column is notes for follow-up. And each meeting, we start with high-risk issues and then just continue to make our way through the registry, noting any action steps that are needed. So this really helps us to close the loop and ensure all follow-up actions were taken. So this might be things like rescheduling a missed appointment or making a referral to a specialist. And it's also a really good time to brainstorm new strategies for engaging individuals who are disconnected from care. So we're still in the early stages of this project, but already seeing some promising results. As I said before, the initiative involves 4 of our ACT teams that are located at the hub, who really benefit from having a co-located FQHC on site. We do have a natural comparison group in our 2 ACT teams that are located elsewhere. So as you can see from this graph, in 4 months, we were essentially able to double the rate of A1C screening for the intervention group, which is occurring during a pandemic, which I think is quite notable. And we also saw similar gains in blood pressure and BMI and cholesterol. And so at this point, about 37% of individuals in our hub-based ACT teams have now engaged in care with CHN. So while we've definitely seen some successes in using data to impact health measures, we've also experienced challenges and learned some important lessons along the way. So I think first is that moving from mental health to a whole person approach is a big culture change. And I don't think that it's, something that's brand new, but it remains important to acknowledge that we're asking people to change ways of thinking and practicing and operating that are really deeply entrenched in what was traditionally a very siloed healthcare system. And related to that, we're asking staff to collect and pay attention to health data. And I think a potential pitfall here is that the data can take precedence over the person, or that staff worry that that's what's going to happen. So I think it's really important to keep it human. These are numbers. So while data provides valuable information, it's not the whole story. And data is really just a tool to help us see where we might be missing something or where we need to focus our attention. And then for people who we've not been successful in obtaining any health data on because they're disconnected from care, it's really an opportunity to explore the reasons why that's happening. So is it because they had negative experiences with care in the past? Is it because nobody's checked in with them about their health in a while? Is it related to transportation issues? So it's really important to keep the conversation focused on the person and how we can support them to take a more active role in their health. Another challenge is that we're asking staff to collect data and pay attention to it and use it. So in other words, we're asking people to do more. So it's really important to think about how that can be integrated into existing workflows, existing documentation, and to really make it as simple as possible. And also to make sure that there's continuous feedback or extra support offered around the use of this data so that people aren't feeling like they're just entering data into a black hole, but that they're getting information back that's actionable, that can help support them to do their jobs better. And finally, I've mentioned earlier that we have been able to obtain funding to support some of this work. Virtually none of the work is directly reimbursable. So a continued challenge is sustainability. And we're absolutely committed as an organization to developing our whole health model. So capturing key health data is really important to opening up opportunities for new partnerships or for value-based contracting. We're also continuously working to expand our capability to capture actionable data and to use it to improve health outcomes. Thank you.
Thank you, Emily. I think really excellent examples of how data can change not only health outcomes of the people we serve, but also the work that staff do themselves. So as usual, please, if you've got any questions, want further discussion with this, please use the information here. And we have a couple more sessions coming up. They're going to talk about how to do change management within an agency to take account of the different use of data within an agency. So please stay tuned for those. Again, thank you, Emily, and thank you for taking part, everybody, in this webinar.